So just going to demonstrate an anterolateral thigh free flap marking up, which is something that's fairly routine, fairly standardised, but there will be variations. Everybody has little differences, but this is essentially the way I do it. Patient undressed, uncovered, obviously below the knee, and ideally up to the ASIS, anterior superior iliac spine, which we can either palpate. Often, in a clinical setting, you leave the underwear on to save any compromise and embarrassment. We have inspection initially to look for any scars, particularly knee replacements, hip replacements. Also a good time to ask about any injuries people may have had to the leg when you're trying to decide which leg is favourable. Varicosities can be prominent on the lateral side, anterolateral area as well, and it'll help you decide which leg is useful. I tend to always Doppler each leg in turn and decide which has got the best areas for perforations. Positioning-wise, toe pointing at the ceiling, lining everything up with the patella and the ASIS, and obviously you can see here, demonstrate quite easily, if the foot has dropped off one way or the other, which is particularly prevalent if someone's had a hip injury. They can often be sitting like this and it can malalign your markings. So just taking a marking pen initially, we just mark out the patella and pick out the most superior and lateral aspect of the patella, which is around about here. Okay, and then we just palpate, often again, excuse me a second, anterior superior iliac spine, which is here. Okay, and one would obviously then, with a tape measure, be able to roughly pick a straight line between those points, as demonstrated here, and measure a midpoint. So I take that all the way up to the end. Yeah, there we go. So we're at 43. So we know that our point is going to be half of that. So around there. And then you can essentially draw a dotted line along this place, along this juncture, to give yourself an estimation of where your vastus and rectus separate. Okay. So that's all that I do in this instance, and then we start Dopplering, knowing that within a 4 centimetre area there's going to be the majority of the perforators. Most of them will be based around the lateral distal aspect of the circle that one would draw. So now, a bit of gel. It's not his fault, but there is a little bit of hirsutism here that we're going to have to put up with which will make a bit of a noise on the Doppler. And also my participant is much more muscular than a lot of my elderly patients, but we will do our best to demonstrate using a handheld Doppler. Fairly standard perforator triphasic waveform. So what I tend to do now is I move off this perforated side to check that it's isolated and coming out towards the probe directly. So I've checked in all four quadrants and just working around to make sure where I can pick up the just mark it. And obviously we don't know any flat dimensions usually because we're waiting for measuring at the top end at surgery, so you're trying to get some affiliated perforators. Not the easiest to lag, but there's definitely something there. What I decided to do in this instance is to mark it, and then see if I can move around it to look for any other areas around it. So let's just see if that correlates quite well. They're fairly close together. They'd work for a usual or reconstructive size flap. You'd probably get both of those within the skin paddle. I'm fairly happy that those two are coming out directly to the skin. this one's the more proximal one is obviously quieter than the distal one, but I think that would work in terms of free flap reconstruction, and would also demonstrate, just check that there isn't any superior branch or TFL valves might act as a bailout in the future if we have any problems further down. Of course, there's no way of knowing if this is a intermuscular septum or whether they run directly through the muscle at this point. Indeed, even if they are part of the rectus system or the vastus system, but in general, with these flaps, it's about identifying the perforators and chasing them along to a main pedicle until you're comfortable with the size of the vessels and you have the length of pedicle you need. Okay, so I'm not really finding any more here. I would obviously now go and check the other leg and see which perforators are deemed better or loudest. And you can obviously design a skin paddle that is going to give you enough pedicle length, because pedicle length may be an issue here. And if you wish to have, if you design a skin paddle that's this side of the perforators, then you're going to have a much shorter pedicle length into the groin. If it is this, if it is this design, that can lengthen your pedicle, and of course you have the runoff of the pedicle, which will give you a vastus chimeric block if needs be.
What sort of skin incision would you make on those two perforators then, Paul?
Well, again, it will depend on the size of the flap that you need, but yes, correct. It's worth indicating that we would essentially make an incision that is along these lines. I'm trying to curve it into the groin to give me ease of access at the top end. So you'd be looking at something like this as an incision. This would allow you to clearly peel. I mean, we tend to all of our flaps subfascial, peel the fascia down and identify where the perforators are coming through, and being careful that we're not undermining our flap on the way through, and that we're making a wide base for our flap and through the fascia, lifting it down and looking for your perforators. But that's the sort of distance you need, and you're essentially looking at a flap that looks a little bit, like this in generality. Okay.
Super. Thank you.
Cheers.